Okay, this is the last of the renal and hemodialysis PowerPoints. And this one will talk about hemodialysis as a process. So, roughly speaking, in the 40s is when we started dialyzing patients. And basically what happens in hemodialysis is the filter of the kidney acts like the nephron. When we start dialysis when the patient's uremia can no longer be adequately managed conservatively, and when the GFR is less than 15 mils per minute. However, as I said in an earlier presentation, we have found, since we've got better modes on continuous renal replacement therapy, if we do intervene earlier, we do manage to save kidney. But it really depends on what else is going on with the patient. We do give it via some kind of vascular access device. So when they're in a chronic renal failure or chronic kidney disease, they will have either an AV fistula or an AV graft. They can also, but in an emergent situation, they would have a temporary catheter. In our hospitals, we call them Quinton catheters, but they are a temporary, they are still a central line, and it sits in a large vein, and there is an arterial side and a venous side, although it doesn't actually use an artery, but basically one to push the blood flow back and one to pull it out. And the fistula is anastomosis of artery and vein, and it shunts the arterial blood into the vein. And a graft, you can see there's a loop graft here between an artery and a vein. And remember, when you're assessing, you need to check pulses distal to the site, and you're looking for to hear a thrill and feel a bruit of that. This is the temporary, this is a picture of a central line, and it's for immediate access because the doctor can put it in right there at the bedside. It's percutaneous cannulation of internal jugular or femoral, as I said in an earlier presentation. They use subclaving as a last resort because some patients can't get the graft or fistula, and they'll put in a device that looks like the temporary, but it'll be one of the tunnel catheters, and it'll be a permacath is what they're called. And they usually use a subclavian vein for that, so they like to reserve it for that. It's double lumen. It's marked only for dialysis use. Dialysis owns it. They change the dressing. They flush it. They do all of that. Jugular vein, there's a lower incidence of thrombosis. Femoral is definitely for short-term use only. Patient has to be on bed rest with their legs straight when they have a femoral catheter, and because they're at an increased risk for kinking it, and then if they're getting dialysis during that time, it interrupts the flow, and there's a lot of problems with that. And the groin is a dirtier site. When you have a patient with a dialysis access catheter, it should not be used for any reason except for dialysis. We don't give any blood or give any meds or blood draws through that, although dialysis staff can. And we want to minimize the risk of infection. You're going to treat it like a central line. What happens at the end of dialysis is dialysis will clean the site and change the dressing and all of that. They'll flush the lumens, and then they'll instill heparin, and they instill a large amount of heparin, like 1,800 units or 1,600 units. It'll say on the side of the catheter how much to put in, and so it just kind of dwells in the catheter to prevent thrombus formation. So that's why you can't use it for any other reason, because then the next time they do dialysis, the first thing they do is they aspirate out that heparin. So they withdraw that heparin from each lumen, then flush, and then start their dialysis. So that would be why you can't use it. If it's an emergency and you have to use it, then you have to try to remember that you have to withdraw that heparin. This is a picture of a dialyzer. This is the filter part of the dialyzer. Inside the filter, and you can kind of see in this picture that there's little gray lines. There's like 1,000,000 straws, and I'm not lying or exaggerating. They're about the size of like a filament in like some of those Christmas decorations that you see. They're and I can't remember the name of those lighted filaments, but there's a lot of straws in there. What they do is they create the semi-permeable membrane. The filter is is hooked into the dialysis machine, and one end will hook up to the patient. Well, both ends will hook up to the patient. But what will happen is the blood will flow around the filters, and the dialysate will go in, and that's how gas exchange. That's how the diffusion and the osmosis happens. Sorry, and I said it wrong. Blood runs through the fibers, and the dialysate runs around them. It's a one-time use, but because these filaments are or straws are very small, they do have to heparinize it. Some of them are heparin impregnated, but part of their prime process is to prime it with heparin. So that puts the patient at risk for bleeding post-dialysis. Components of hemodialysis. This has everything except for the machine. But so this is our patient. This one has a fistula that's accessed. The machine itself has a pump. What the pump does is keep the blood moving, because once it becomes static or stasis occurs, then your filter is going to clot off. If your filter clots off, your patient isn't getting dialysis. If your filter clots off, isn't getting dialysis, then they have that much of a blood loss and they're already at risk for bleeding. So once it starts clotting in here, the dialysis has to change that filter. So it prolongs the time and it makes it harder for the patient to get their treatment. This is also true if I'm dialyzing somebody who is septic or has rhabdomyolysis and has those large molecules. They don't clot off, but the molecules themselves are too big, and so they'll clog up. Now, when they're dialyzing, they measure the pressure across the filter and how much pressure it's taking for the blood to go through the filter. So what I'm saying with that is that, generally speaking, that's part of the dialysis. That's why they stay there. The dialysis nurse's job is to monitor those pressures, and they want to actually intervene before the patient doesn't get their blood returned back. They may have heparin infusion or some kind of anticoagulant. They'll have dialysis outflow and a dialysate drain. So what happens is we're putting in this this electrolyte balanced solution. Sometimes there's bicarb in it, sometimes there's potassium. There's always sodium chloride in there, and we want to even out. So if somebody's hyperkalemic, it won't have potassium in it, so that the potassium can cross over into from the patient's blood into the dialysis machine, and then get excreted as what they call effluent, which is the output. Most of the machines these days are weight-based, and so they're measuring how much weight each bag is and how much weight they're taking off in the effluent bag. Before treatment, the nurse should complete assessment of fluid status, condition of access, temperature, and skin condition, as well as usually there's a daily weight involved. During treatment, the nurse should be alert to changes in condition and measure vital signs every 30 to 60 minutes. Now, this is if the patient is on the floor. Or if they're in a dialysis center, that's what the dialysis nurse will do. Complications, big one is hypotension. Because of a rapid removal of vascular volume, they get lightheaded, nausea, vomiting, seizures, vision changes, and chest pain. If that happens, we're going to slow the rate of dialysis, maybe give them a bolus of saline, and we want to make sure that we hold their blood pressure drugs prior to dialysis. Other complications include muscle cramps due to a loss of sodium and water. If that's the case, you want to slow the rate of the dialysis, give them a bolus of saline. Loss of blood, as I talked about with the dialyzer, if the dialyzer clots off, then I'm not able to return the blood and they lose a bit of blood that way. Accidental separation of blood tubing, that's pretty massive because that blood pump turns at a minimum of 300 mils per minute. And so if that comes apart, there's going to be blood everywhere and they could bleed out from that. Too much heparin, as I talked about, and bleeding at access site. Infection is also a big complication. Hepatitis B and C, usually that's hepatitis C if that is the case, and at this point there's not a vaccine for hepatitis C. Another big one is disequilibrium syndrome. It's called dialysis disequilibrium syndrome, and you get a rapid change in the composition of extracellular fluid as you're pulling fluids off. They're moving from the vascular space or to the vascular space from the extracellular fluid. So they're moved more rapidly from the blood than from the CSF and the brain. So what you start to get is nausea, vomiting, confusion, restlessness, headaches, twitching, jerking, and seizures. You want to slow or stop the dialysis. You want to infuse hypertonic saline to replace lost sodium, albumin, or mannitol to draw fluid from the brain cells. And it's more commonly seen in initial treatments. Hemodialysis cannot fully replace normal functions of the kidneys, but it's pretty close. And they can ease many of the symptoms and can prevent certain complications. Now, in the last 15 years, we've been doing CRRT, probably a little bit longer than that, but we've really perfected it with better machinery, which has helped us in the last, I'm going to say 10 years. It's an alternative or adjunctive method for treating AKI. It is still dialysis, but the continuous part means that you're not drawing off as much fluid at one time. You take off a slower amount. It's continuous over 24 hours, 48 hours. So where in a 3-hour dialysis treatment, they might have taken off 1,500 mils, let's say. In CRRT, they still try to take off the 1,500 mils, or liters, sorry, is what it, now I can't remember, kilograms, then, or 1,500 milliliters, sorry, I confused myself there. Then they would do that over 24 hours instead of over 3 or 4 hours. Acid-base status, electrolyte balance adjusted slowly and continuously. And the renal replacement part is they also give a balanced solution so that so much volume isn't lost at one time. And this, the patient has to be in ICU for this treatment. CRRT versus hemodialysis. There's no right way or wrong way, but CRRT is continuous rather than intermittent. The patients tolerate it better, but it requires more manpower. Solute removal by convection, no dialysis required, and less hemodynamic instability.